Good evening, everybody. I didn't get that loud enough. Good evening, everybody.
Good evening.
That's much better. Thank you very much. We cannot do the educational programs that we're doing without the support, the financial support that we get from corporations and from the pharmaceutical industry. And for tonight's program, we want to thank Celgene and Sanofi-Genzyme, and I hope that you could all thank them as well. All right? It's very, very important that you all understand that they are not here to just get you to use their medications. They really don't care what medication you're using when you're attending our program, as long as that you are here to learn about the different things that you will hear about tonight. All right, so our first speaker tonight, we're switching the order of things around. You have agendas on all your tables. It shows that Mitzi Williams, the doctor, Mitzi, neurologist, was going to be speaking first, but instead, we're going to have your local favorite, and that's Rebecca Rahn. She's going to speak first, all right? And then Dr. Williams will speak second. So, let's talk about Rebecca first. Rebecca Rahn is a physician assistant and associate director of the Multiple Sclerosis Center at Augusta University Medical Center in Augusta, Georgia. She is a multiple sclerosis certified specialist. Ms. Rahn is an active investigator for ongoing observational studies evaluating the safety and efficacy of different MS therapies and has been published in such journals as Clinician Reviews, a Rehabilitation Psychology, Multiple Sclerosis and Psychology, Health and Medicine. In addition, she has been an invited presenter for numerous peer-to-peer and patient educational programs on topics related to multiple sclerosis. Mrs. Rahn also currently serves the coordinator for the World MS Day in Augusta and the Augusta MS Center Family Day events. She was awarded Outstanding Alumni for the Physician Assistant Program at Augusta University in 2015. Let's welcome Rebecca.
Thank you.
You know what you're doing, right? That's very good.
You're at a time.
Thank you.
Hello, hello. Thank you all for coming out. I appreciate it, especially on a busy night. Often we get busy. So we're going to focus a little bit in the beginning about balance and the impacts that that has in our lives day in, day out. So later on you'll get to hear about physical balance. But first we're going to start about emotional balance. So let's look at the kind of first as a starting point. So often when I think about emotion, especially for many of you in the room, you probably grew up hearing, oh, like that woman, she's so emotional, or he's emotional. And we think about a certain perspective when we talk about emotion. So we think about either being sad or happy or crying or laughing or certain specific feelings for a time. But when we get into details about it, we're going to focus on some extra things. So our goals for tonight, and this is just kind of the first part, is to first understand the impact of MS and how that affects us emotionally, both as an individual but also as a family unit. And then we're going to look at some of the daily challenges that we often, some of those are kind of the typical things as far as how we eat and how we get dressed, but also bigger things about like how you would come to a program at night if you wanted to, or working out. And last, we're going to look at the role of change in life, because we all have to change whether we want to or not. So first, what is emotional? What is emotion in general? So the Oxford English Dictionary defines it as a strong feeling derived from circumstances, either mood, looking at the relationships that we have. It's different from reason or knowledge. And I like what is added by Merriam-Webster, because they say too how that's accompanied by physiological and behavioral changes. So it's not just what we feel, it's how that affects us day in, day out, whether that causes us to have some change. So when we look at the emotional impact of MS, we're really looking at those two different things. One is our feeling and how we feel about it, happy, sad, angry. And then the other thing is what that does in our daily life, how that affects us behaviorally as far as changes. So when we're first diagnosed, kind of we all go through similar symptoms. I think of it like grief. So I kind of outline that. And some people like that, and some people kind of have a strong feeling against it. But when you think about grieving, it's kind of going through a loss of some sort. And when you're diagnosed with a chronic illness, MS being one of them, we are suffering a loss. So there's these 5 stages of grief that we all experience. The first one is denial. So all of us know what that is. It's the no, that can't be true. No, I don't know if I believe that. I don't agree with that. When we're in denial, sometimes that leads to us not going back to the doctor. Sometimes it means we're going and getting a second opinion. So denial is often a dangerous place, because if you're denying that you have a diagnosis, that may lead to you not ever starting treatment. It may lead to you going years before you really acknowledge or accept what's going on. But when you look at grief and the stages, these don't necessarily happen 1, 2, 3, 4, 5. Sometimes they're circular, and we kind of start with denial, and then time goes on and we accept things, and then we come back and we deny it again, all over again from the start. So this isn't necessarily something that you kind of pass through and then you're done with. You may experience it again. The second stage is anger. And this can be directed at any number of things. It may be directed at, as an individual, at yourself, angry that you're sick. It could be at MS itself and mad about the disease or that it exists. Sometimes people get mad at me as a provider, and I take that, but there's not a lot I can do about it as far as how you're feeling moving through things. But most of the time, the anger is at those we love the most, whoever the friends and family that are closest to us. And sometimes for no reason. You acknowledge that you're mad or taking it out on somebody, but you don't really know why. And often it's this underlying grief that we're dealing with. So bargaining is, I think of it, it's like the what ifs, or all those if questions that we ask. So what if I had found out sooner? What if I got a second opinion? What if I took a different medicine? What if I ate better? What if I fasted? What if I start exercising? What if I lose 400 pounds? Just kidding. But when we go through all of those what ifs, what goes along with that is guilt, because sometimes we feel like we did something wrong to get us in this place. And so it's like, well, what if I did something different? And often it's looking in the past. So that's not really helpful when you carry all that guilt around and feel bad about what you're dealing with, because that doesn't necessarily in and of itself lead to change. Depression is the fourth phase, and maybe the one that we think of the most. I tend to think of depression just as being sad, and lots of people think that. They're like, well, I can't be depressed. I'm not sad. I don't cry all the time. And they have in their mind what depression looks like. But depression can be brief. It may be a couple weeks or something that we move through. And it can also be a longer period of time. So we're going to look in a little more detail about depression because it affects so many of us. And this fifth phase, this is probably the most important, is acceptance. This is the phase that I hope that everybody always gets to, regardless of whatever the obstacle is that you're facing. But certainly if it's an MS diagnosis, it's once we get to acceptance that then we can move on and start to take charge and plan for the future and have hope. So, like I said, sometimes we backtrack again. And so maybe it's a relapse or a new symptom, and then you delve back into some of those earlier feelings all over again. Or sometimes it may be something else in life that causes our emotions to change. But these are phases that we all go through when we're dealt with a diagnosis. So regardless of where you are in life, these impacts will occur. So I added some extra info on depression in particular, just because it's so common. So I've seen statistics where it's maybe like 1/4 of people who have MS, but I've also seen where it's just 1/4 of Americans, just the general population, who suffer with depression. So it's not isolated just to having MS, it's something that affects all of us. And I've seen higher numbers where it's maybe 50% of MS patients, or even as high as 75. And I said in the beginning, a lot of times we think, oh, well, women are the emotional ones. But there's actually equal rates of depression in women and men. So it's not something that's only one gender is going to experience. So these first signs, like sadness and empathy and hopelessness, that often resonates with people. But some of these other things, like loss of interest or weight change, either losing a lot of weight and not having any appetite, or eating everything and gaining 20 pounds in a rapid change. It could be either one. It can be sleep habit changes, where you're sleeping all the time, or you can't sleep. So a lot of times I ask people, they'll say, I just can't sleep at night, I'm tired. And when you try and find out why, they're like, I don't know, I just lay there, I just think about stuff, I can't get my mind to turn off. And sometimes that goes back to mood and depression, and that can actually prevent you from being able to rest and prevent you from being able to get that good sleep. So fatigue is a big one on here. We talked about agitation and anger, but fatigue is a big one because so many of us experience that as a symptom of MS. And so when you're feeling fatigued, you may just say, oh, my MS is flaring up. But it may be a result of underlying depression or mood changes or other things that you're dealing with, and not just the MS overall, or not just a bad night's sleep. maybe we have to address the mood first. The last one on here is suicidality. And I think in today's society, that's a really important one to address. Historically, we kind of shame that, or you didn't talk about it. You may know one person who was affected with depression or feeling really down, like they just didn't want to go on. But it's so important that we recognize it and talk about it, because lots of people feel that way. Even if they're not actively planning to do something, they may still feel that way, as if they wish they weren't around. So I put up on here the suicide prevention hotline, and I know Stuart said to turn off your phones, but I hope you put this number in there, because you never know when you'll need it, if not for you, for someone else. So that's a number you can call anytime, day or night, and have someone to talk to you. Because sometimes we feel, down in the moment, maybe the middle of the night or an afternoon, and then with the morning comes a better day. So we always want to have that reason to live for and hope, and sometimes we need someone to remind us of that. So I can get it for you later. I got it in my phone. But if you need it, it's there. So the next thing to think about, all of that is stuff that we go through when we're dealing with MS and dealing with that diagnosis. But our family members, and by family, that may be friends, it may be neighbors, it may be coworkers. I know I call my coworkers a work family for a reason, because they're very much a part of my family. So this is kind of a big term. So our family members also grieve, and they go through those same stages. Sometimes that denial, I've heard many of you say it, it's that, oh, but you look so good. I don't understand. That can't be, because you look so good. And so you're dealing with someone who's questioning you and whether or not you have a diagnosis. And they're dealing with that. They may say, well, let's get another opinion. Let's go to another doctor. Let's see if we can find out what's really going on. Sometimes along with that is isolation in a different way, where maybe your friends pull away from you because they're like, oh, I don't know what to do with that. I don't know anything about that. And then all of a sudden you're reaching out and maybe the family or friends aren't there. So this can be a hard one to deal with. And sometimes as a friendship or a relationship, we never recover from that. You just kind of get stuck in the denial and don't move on. But we experience these other things of grieving too. So anger from family, maybe them yelling at you and saying like, why didn't you clean up the house? You were here all day. Why didn't you do anything? And you had a bad day. You felt tired. Or, why couldn't you work? Why couldn't you come to my football game? Why couldn't you XYZ? And so it's, that not understanding what the symptoms are, how you feel day in, day out. So bargaining is similar whether it's us dealing with it or a family member. That tends to be when you hear those things like, well, if I take you to this appointment, or if we do this, if we fix up the house, if we get that handicap van, whatever the ifs may be, is that going to lead to a change in the MS? And so we're kind of, again, pulling for that hope of what if. And sometimes, like with ourselves, it could be that what if of, what if I had seen it sooner? What if I had told them to go to the doctor? What if I had made them address it? And so our family members carry that guilt that maybe they should have seen it sooner or intervened or done something differently. So these can kind of cycle through. So just like all of us, depression is on the same list, and that can be either related to the illness or even to the change of the social structure. So once we kind of move through all those stages, acceptance isn't necessarily being really happy. I think sometimes we want that. We want to be thrilled about MS or kind of shouting about it. But that's not necessarily what acceptance looks like. It's more kind of moving forward and finding the new norm or the new family dynamic of what our roles will be and how we're going to work and get things done. So these are kind of very typical early on, but again, like we talked about, they can cycle through over and over again, depending on how you are and what else is going on in your life. And you have to remember that sometimes other things happen in life too. So it could be a death in the family or a new job or change, and then all of this gets impacted all over again. So looking at the emotional impact, we're kind of going to move now towards what our daily challenges are and how our mood affects our ability. So everybody has these same challenges, and I put it in the medical terms because we have terms for everything. So activities of daily living are the things you have to do just to stay alive. That's eating, truly like feeding yourself hand to mouth, dressing, bathing, toileting. They're kind of your basic functions. And that's different than your instrumental activities of daily living, which are, so not just eating, but what kind of food are you going to eat? Where is it going to come from? If it's from the grocery store, who's going to do the shopping? Once it gets home, who's going to cook it? And after you cook it, then who's going to do all the cleanup and prep? So the instrumental activities are kind of much broader than just our daily living, day in, day out. But we have to all figure out a way to do it, and it may be different for everybody. So managing funds or managing money, that's not just paying bills, but it's where's the money going to come from? How are you going to save it or plan for the future? All these other things that go together. So regardless of living with MS or not, these are challenges that we all face in the room. So as far as the emotional impact of it, for one, what our responsibilities and challenges are all change over time. So I will remember probably forever, I have a baby brother who's now old in his 30s. But when he was young, when he first got his real job, I remember him calling me up on the phone and being like, I don't have any time for myself anymore. All I do is work. And then by the time I eat dinner, it's like I'm exhausted and it starts all over again. But at that point, he was a single man, and I was married, working a full-time job, and had 2 kids. So I'm laughing at myself, you have no time? You have no idea what no time is. Because what his responsibilities were compared to mine, I thought paled in comparison. But that's kind of a natural thing that happens with life. We have different things. We get jobs, we lose jobs, we get married, we get divorced, we have children, our families expand. These are all things that everyone faces day in, day out. The difference with MS is that our symptoms may affect our ability to deal with that. So if you have overwhelming fatigue, your ability to manage and work a full-time job may be kind of the icing on the cake that tips you over. That may be more than you can deal with. So when you add MS and a disease to it, then our ability to complete our to-do list may not balance out in the end. And the other things are, back to other emotional components, our depression, our anxiety, worrying about whether we'll be able to do something or not, may limit our plans that we make for ourselves and whether we want to participate in an activity at all. So sometimes it's hard to plan for something like a wedding 6 months down the road because you don't know how you're going to be feeling the day before or day of and whether you'll be able to commit to something that you need to do. So it's ups and downs day in, day out. And people will say, well, I have good days and bad days. It all just depends. So looking at that or kind of coming on that and what do we do about it is change. That's kind of the next phase of everything. So change is inevitable. We all do it. Looking at my brother going from, being a college student who really did nothing all day to then having to be a full kind of working person to looking at me and then having children and how my responsibilities shift. Regardless of who we are, we change. And I talked to my grandparents. They're in their 90s. And so you ask them, how their life is different now than what it was maybe when they were teenagers. They may feel the same and feel like they're the same person inside. They don't feel any older. And if you ask them, they're not old. But what they're able to do, how living life and completing those daily tasks are now compared to maybe when they were in their 50s are night and day. So it is what it is. We all have to change. The main thing is resilience. And so when you're faced with the obstacle or adversity, when you have to change, what do you do about that? Is it something where you see that obstacle as an opportunity to grow? Or is it something that maybe pulls you back in your shell and stops you in your track? So we every day have opportunities where we can grow and face adversity. And MS is one of those things. There may be limitations related to what our symptoms are, how it affects us, but we can use those as a chance to change. And while the science is working to change MS, we can change our response. So we may not be able to change having the diagnosis, but we can change what we do with it. So these are kind of some things, kind of the highlight that I want y'all to kind of remember, really focus on and take home, because this is what you can do about it. How do we change? So there's 3 things. One is to understand your situation, understand MS and who you are, manage the things you can, and then shift what your priorities are. So understanding yourself and your situation, step 1, praise to everybody here, you're listening to a talk, you're learning about MS, you're trying to get extra information about what you're dealing with. That's the most important thing, is to kind of face it head on. But also, know how it affects you and what your strengths and your weaknesses are. Some of us are pretty flexible and adaptable. So that's helpful in MS. If the symptoms come and go and we don't know what to do, being able to go with the flow is a good thing. However, that may make you less good at planning for the future. And if so, you may need a partner by your side or someone who's going to reel you back in and get you focused again on, okay, but what about a year from now? What about 5 years? What about 10 years? If you're someone who's a big planner, you're not suddenly going to not care about the fluctuations day in, day out. That may be really stressful. But having the ability to plan for whatever outcome may be. So if it's a good day, what are you going to do? If it's a bad day, what are you going to do? What's your plan A and B? That may be able to help you get through some of the waves and deal with some of the adversity. So other things are manage what you can. So some of those, maybe with the aid of a doctor, or kind of building a care team. And Dr. Williams is going to talk to us in more detail about all of these things. How do we take control and manage what we can? So with MS, if you have a condition, maybe you can take a medicine to prevent the long-term outcome. Can you take better control of your symptoms? So I can't tell you how many people come to clinic and they're like, well, I'd love to go to the movies, or I'd love to go out to dinner with my husband, but I'm worried, what if I have an accident? What if I can't get to the bathroom in time? That would just be devastating. So maybe a symptom as far as your bladder control, there are lots of things that your doctor can do about that to help control the symptom. And that may help you to be able to go out and do more as far as the things that are most important to you, like spending time with friends and family. Other things are comorbidities like diet and exercise and smoking. So a lot of times we focus just on one little piece, just on our MS, and we ignore all other aspects of our health. And sometimes that isn't the MS. Sometimes it's other things we have to deal with. Maybe that fatigue that we were talking about is because of sleep apnea and not sleeping at night, or maybe it's because your thyroid is off, or maybe a vitamin deficiency. So paying attention to other things that you deal with is really important as far as taking control and being able to improve your quality of life. And then other things, we talked about planning for the future and fostering supportive relationships. We all have those friends that are going to bring us down. And we talked about like those phases of denial and anger. And people need to go through that. But being able to surround yourself with positive people that are going to be there and support you and help you go to appointments or make up for your losses. I can't necessarily at this age change the core of who I am, but I have learned to surround myself with people who are different and can help me along. So the last thing is kind of shifting your priorities. So in America, in the States, and I grew up feeling this way, it's always do more, be more, get another degree, get a better job, accept the promotion. You can have it all. We all hear that all the time. But that may not be what the most important thing is. Sometimes it's better to turn down the promotion to be able to manage your energy and have better quality of life. Maybe, in part for me, after having children, that just is a natural thing that shifts priorities. And so I want to be able to spend time with family. And so I have to change things as to how can I have energy so that when I'm done with my work day, I'm able to spend time with the kids and play with them and have that quality time. So these are things that happen to all of us, but we can do intentionally. We can say, okay, I get a little tired around 3 o'clock, so how can I shift my priorities to be able to get the things done that I need to and be able to move on? And that goes to kind of setting realistic goals. So if my plan is to be an astronaut, that's my dream and my goal is to go to outer space, I'm probably going to be disappointed. I didn't study aeroscience. I've never been to NASA. I'm not even sure we're sending rockets to the moon. I don't know if these are things that are happening. So my ability to accomplish that goal is going to be a disappointment and lead to depression. But if we can align our goals with what our abilities are and be kind of satisfied with what we're doing, then we feel really good about things day in, day out. So part of it is being able to say, okay, these are the things most important to me and the things that are going to make me the happiest living life day to day, and what can I do to accomplish that? And how can I find other people, other friends, other situations that can build me up? So looking at it one more time, this is kind of just a summary of the things we've talked about. So one is just the emotions of MS, being diagnosed, how that affects us and our family. Another is looking at the daily challenges that we all have to face, regardless of if we live with MS or not. And then the last is being able to change and be flexible and reevaluate what's important to us so that we can move on and be successful. So I've heard a lot of patients say things like, I may have MS, but my MS doesn't have me. And I think we've all heard like that serenity prayer that's now kind of an AA association, but for God to grant you the serenity to accept the things that you cannot change, the courage to change the things you can, and the wisdom to know the difference, right? Y'all are saying it with me, so you're familiar. So when we look at these things, when we look at the emotional impact, some of it is what it is. But being able to move past that and get to a point of acceptance where we can change things and take control, that's what's going to lead to us doing the best. So at that, I'm going to turn it over to Dr. Williams, who's going to tell us some more even about MS and self and what it is. So thank you.
Let's thank Rebecca Rahn again, right? She did a good job. Great. Now you get to listen to me babble on. By the way, I don't believe in that stuff that, I don't have MS and MS doesn't have me. I know I have MS, but I had to teach MS to live my life. Live the way I live. And if it doesn't like it, then get the blank out of here, So I live too much and I do too much. So it had to, take a toll and step back. Now, let's welcome Dr. Mitzi Williams. She is a neurology MS fellowship, right? Dr. Williams' research interests include MS relapse and the course of MS in minority ethnic populations. In addition, she has authored numerous peer-reviewed articles in journals such as Neurology, Clinical Practice, Stroke, and Annals of Pharmacotherapy. Is that it? Very good. Thank you. Yay for me. All right. In addition, Dr. Williams has spoken both nationally and abroad in conjunction with the Accreditation Council of Medical Education. She is currently a trustee for the Georgia chapter of the National Multiple Sclerosis Society. Please, let's welcome her for all that she is doing for the MS community. Dr. Williams she just wants to improve everybody's health outcomes and educating her patients. So let's say thank you. See? There you go. Thank you.
Good evening. How is everybody doing tonight? It's okay to talk to me. Don't be afraid. All right. Very good. So how's everybody doing? Everybody's doing okay. I see we've got some salad and some bread. That's very exciting. People are usually a lot more active when they have a little sugar, a little food in the system. So, as Stuart said, I'm Dr. Mitzi Joy Williams. I am in Atlanta right now at the MS Center of Atlanta. I've been an MS specialist for the past 10 years, and I actually used to be the director of the Augusta MS Center not so long ago. So I'm glad to be back in my old stomping ground and see some familiar faces as well as some new faces. I see Loretta looking at my shoes. You like those, don't you? You like those? Okay. Well, they have a time limit, okay? So I got about 30 minutes before my feet start hurting. All right, so let's get through it. Okay, so before we get started, I usually do my customary poll. How many people here actually have MS? Raise your hands real high. Family members and friends of people with MS, raise your hand real high. People who came because they wanted some chicken dinner at the Marriott. Tell the truth, shame the devil. Tell the truth. Okay, very good. All right, so I've got kind of a hodgepodge of topics, so I'm going to be talking about a lot of things. But as Stuart said, we're going to save questions until the end, so hopefully I'll get you some information that you've not heard or maybe review for all of you. All right, so we'll start out talking about what is MS. So I'm going to start out with an overview of MS. Somebody tell me what MS is who does not have a mouthful of bread or salad. Yeah, what's MS? Multiple sclerosis. Somebody said central nervous system. All right, call out words that come to your mind when you think about MS. Pain in the butt, right? I get that one a lot. All right, what else? Memory trouble. Yep, we're going to talk about symptoms in just a little bit, but what about a general definition? So, central nervous system, which includes the brain, the spinal cord, and the nerves to the eye. Anything else? Autoimmune disease, right? Meaning the immune system, the part of the body that normally attacks viruses and bacteria, gets confused and attacks a good part of the body. What part of the body is attacked? The myelin, right? I see you in the back. I see you in the back in the blue. All right, girl. Okay, so the myelin, which is the coating of the nerves, right? Myelin works like insulation in a wire. So I have these, I don't have them on, but I have these wireless headphones that I love to wear. And my 18-month-old likes to chew on my headphones, right? Because she thinks it's some type of food. So if little Sarah chews on my headphones too much and tears up the coating, what's going to happen? They'll have a short, right? And so when I try to listen to my music while I'm doing my charts at the end of the day, they're not going to work. And that's essentially what happens to the nerves. The immune cells chew up the coating or the insulation of the nerves, and that's what results in the symptoms that people have from MS. All right, so autoimmune disease, central nervous system, myelin attacked, okay, results in the symptoms. All right, but what else is MS? So that's kind of a definition of MS in the scientific sense. But for those of you living with MS, and as Rebecca talked about, there's a lot more to an MS diagnosis than a scientific explanation, right? There are things that affect your future, what you planned for your future. There are things that affect your family, your ability to work, your interactions with caring for your children. And I love this graphic because it has so many words in it, right? So I'll just point out a couple. At the top left, we can see anger, we can see chronic, but in the middle, we see hope. On the other side, we see friendship, we see strength, we see courage. People find out a lot about themselves after an MS diagnosis, and they also find out a lot about the people who are around them, you know? Sometimes people find out that people have a hard time handling when you're going through things, and some people may fall away, as Rebecca said. So there's just so much more than a scientific term that goes with MS. All right, so who gets MS? Everybody, right? So traditionally, we've thought of MS as a disease that occurred primarily in young women of Northern European ancestry. But what we're finding more and more is that, especially in the United States, MS occurs in many different populations, okay? And there were several studies that were released in 2012 and 2013 suggesting that the risk for MS is actually highest in African Americans, which is very contrary to what we've traditionally thought with MS, okay? So we're finding out more and more, but we know that MS occurs in everybody. Currently, it's suggested that the risk may be highest in African Americans, but if you look at the total number of people with MS, people of Northern European descent still make up across the world the majority of people living with MS, if that makes sense. Okay, what about symptoms? Okay, top left, what's that? Right, burning pain, neuropathy. What's on the bottom? Cramp, all right, very good. What's in the middle? Michael Jackson. Okay, what's on the other side? Fatigue, right? That's what some of you are going to be doing after you eat that chicken dinner, right? That's why I'm trying to get done so our last speaker doesn't get you after you go into the carbohydrate coma. And what about the bottom? Absolutely. Urinary issues. That's what my son does. That's not my son. But that's what my son does when he has to go. Well, obviously, it's not my son. But that's what he does when he has to go to the bathroom, okay? So those are just a couple of the symptoms that people can present with, or that may be their first symptoms of MS. We will talk a little bit in more detail about some of the silent symptoms of MS in just a few minutes. All right, so how about the course of disease, right? So many people will say, what type of MS do I have? What's going to happen to me, Dr. Williams, especially when they're first diagnosed? This is a very busy graphic that tries to describe kind of what happens over the lifetime if someone with MS. And so we can see on the far side where it says disease severity. On the bottom of the graph where we see those little arrows, everybody see those? Yes, no, maybe so? Talk to me. Okay, so the bottom where we see the little arrows, that tells us about the MRI activity. So it tells us about those lesions. You know, when your doctor's looking at your MRI, we're looking for those lesions. We can see in the beginning, people have more of those lesions, more active lesions, meaning there are more changes on the MRI early in MS, okay? If we look at the green line talks about atrophy or kind of shrinkage of the brain. How many people know that all of our brains shrink over time? How many know that men's brains shrink a little faster than women's brains? Okay, and MS brains shrink a little faster than normal brains, okay? And so what we can see over time is that the atrophy kind of starts not being that much, but over time that can increase, right? And then if we look at the blue squiggly line, those are the white spots that we see on MRI, and we can see that those tend to increase over time, but once you get to the far end of the graph, they kind of level out. Has anybody ever gone to the doctor and said, Dr. whoever, Dr. Mitzi, I feel like I'm doing a little bit worse, but every time you look at my MRI, you say my MRI looks the same. Has that ever happened to anybody? Okay, all right, so that's because those lesions that we see, they kind of level off after a while, and sometimes there are changes that go on under the surface that we can't see with our current MRI techniques. If you think about an MRI, and I'll talk about MRI in a couple seconds, it's kind of like looking in a mirror, right? So if you go into the hotel bathroom and you look in a mirror, there's a certain level of detail you can see, right? I can see enough to put on my lip gloss, right, and think I look cute. But if I go to Bed Bath & Beyond, or I go to a fancy hotel and I see one of those mirrors that has 10 times the magnification, I can see every pore in my face, and that doesn't look quite as cute, right? And so the amount that we're able to see on MRI really depends on how good the picture is, okay? And then finally, the red squiggly line is the line for disability. And so what we can see is in the beginning, we have these kind of squares that go up and then they go back down to normal. Those are relapses. In the beginning, when most people start with relapsing remitting MS, they have symptoms that come on, go away, come on, go away. But over time, they'll have a symptom that comes on and it won't go completely away. And that's how people accumulate disability over time, okay? You get a little bit left over from each of those relapses. Make sense? Okay, perfect. So diagnosis, how do we diagnose MS? What kind of test do we do when we diagnose MS? Lumbar puncture, right? So whenever I ask a new patient, when you were worked up for MS, did you have a lumbar puncture? And they say, I don't know. I say, well, you didn't have one, right? Because it was a memorable experience and usually not a good one, right? So lumbar puncture, right, is one of the tests. But usually you have a symptom, you go to the doctor, hopefully you see a neurologist, they do an exam, they take a history, and oftentimes during that history, you may recall that 10 years ago, my leg went numb. Somebody said it was a pinched nerve and it went away, and I thought that's what it was. That may have been the first symptom of the MS. So you do a history, you do an exam. There are also blood tests that are done, usually to try to rule out other diseases that can mimic MS. So there are some diseases that can present with similar symptoms. So we want to make sure that we're not mistaking MS for something else. And then we do MRIs. How many people here have ever had an MRI? Okay, gotcha. All right, I've had one too. So we do MRIs of the brain, and often we also do MRIs of the spine. Because when we see white spots in the brain can be caused by a couple of different problems. Every white spot is not MS. But generally, if you have white spots in the spine, it's usually some type of autoimmune disease, whether it's MS or something else. And then finally, a spinal tap if we need to. And sometimes there are other tests that are done to try to see if we can figure out what's going on. All right, so here's our MRI. Okay, and we're looking at these white spots where you can see the arrows, okay? And so basically, the white spots tell us about the areas where the immune system has attacked the myelin. So when we see white, that means the myelin is gone, okay? So white is the absence of myelin. So we can see the areas where the myelin has been damaged by the immune system. And so that's what we're looking at when we're looking at your MRIs. We're looking at those white spots. We're looking to see if you have new white spots. We're looking to see if the old ones got bigger. And then we're also looking for ones that light up with contrast, because those are spots that are new in the past 6 to 8 weeks before you had the MRI done. Perfect. Now, let's talk about cake, because I like cake. Okay, so when we talk about treatment of MS, I kind of look at it as a 4-layer cake. So the reason because I like cake, and I really like strawberry cake. Do you guys have strawberry cake tonight? No, I'm just playing. So I really like strawberry cake. Okay, so 4 layers of cake. So there's a 4 tiered approach when we talk about treatment. So when we talk about therapy, there's acute therapy. So that's, hey, Dr. Williams, I can't see out of one eye. What do? Usually we do steroids, okay, to try to decrease inflammation and speed up your body's ability to recover. We're going to focus on the two middle sections, disease-modifying therapy and symptomatic management tonight, okay? Disease-modifying therapy is the second layer of the cake. Those are the drugs that try to decrease the immune system's attack on your central nervous system, okay? And they do that in a variety of ways. And then there's symptomatic management, because there are some symptoms that we can treat. If you have the numb and tinglies, we can treat that. If there are bladder issues, there are often treatments for that. There are some symptoms that we don't have treatments for, but there are many symptoms that we can treat to try to make your quality of life better on a daily basis. All right, and then rehabilitation is if you need physical therapy, occupational therapy, speech therapy, those types of things. All right, so let's talk about timeline of treatment. For those of you who've heard me give a talk before, when was MS first recognized as a disease? I said, Dr. Williams, why are you quizzing us? Man, we don't even have our entrees yet. Okay, so the first medication was approved in 1993. When was MS first recognized as a disease? Shout it out. 1868. Okay, I heard of 18, right? So 1868, MS was first recognized as a disease. There was a doctor, Dr. Charcot, who is the father of neurology, who must not have had much of a home life because he discovered everything, right? But so he put together the symptoms with the lesions that we see in the brain. So we've known about it since 1868. The first approved therapy did not come out until 1993. But the good news is, if you look at this graph, and this is not complete, okay, there are other medications that have come out since this graph. I couldn't find one that went all the way to 2018. But if you can see, in the beginning, 1993, then we had a couple in the late 90s, early 2000s to 2005, there were several. But look over at 2010. Do you see that? Almost every year, a new treatment for MS, okay? So there's really been an explosion in treatment options for people living with MS. For some of you who may have had MS, was there anybody who had MS in the 90s before there were treatments available? Raise your hand real high. Right. So several of you remember there was a lottery for the first medication, okay? So we have come a very long way in terms of our options and ability to treat and better treat this disease that can be very debilitating. So I'm just going to put a pin here and talk about the importance of treatment. So when we used to diagnose MS, let's say 10 or 15 years ago, what happened was somebody would come in with a symptom, right? And the symptom would seem like it was a symptom of MS. We get the testing and get the MRIs or what have you in the spinal tap, and then we will wait for something else to happen, right? Because you didn't have MS until you had another episode, okay? But what we realized over time is that we're basically waiting for something else to happen to you, and your brain could be accumulating more lesions and more spots over time. So then the diagnostic criteria changed so that if you had a symptom, you had an MRI that was abnormal, then we would usually get another MRI, and if you had a new spot on that next MRI, then we treat you. So we treat you earlier, and now the criteria has really changed so that if you have that first symptom and you have an MRI with spots that look like MS, we go ahead and treat you, okay? We don't wait for something else to happen to you. And the reason being because the earlier we treat, the better chance we have of preventing disability over time. Really, in those first 5 to 10 years, we have a window where if we can get that treatment in as early as possible, hopefully you can do better in the long run. So it is very important that if someone has symptoms, they go to the doctor, they get assessed, and they get on treatment. The other thing that's very important is to stay on treatment. There's some preliminary research that I've been doing that I'm going to present at our European meeting in Berlin in a couple of weeks and looking at people who started on therapy and stayed on therapy versus people who didn't take medicine and how they did. And then we also looked at people who started on therapy but had breaks in their therapy, okay? So maybe a year, something happened with their insurance, maybe they didn't have treatment for a year here or a year there. And the people who didn't stay on therapy did almost as bad as the people who weren't on therapy, okay? So it's very important that whatever you and your doctor decide, you stick to it. If you're having trouble, let them know, okay? So they can get you on a new therapy. And the great thing about it, and we've got a couple of reps here from some of our companies, the great thing about MS treatment is that there's a lot of support and financial support built into treating MS. So I tell people most of the time, we can find a drug for free, okay? Now, we can't get everything else for free, but usually for the MS, we can usually find a way to treat the MS with support from different foundations or what have you. So if something happens, go to your doctor, make sure you find out about those resources so you can stay on treatment, okay? That's my soapbox for the night. All right, so what are our goals of therapy? So a couple things we're trying to affect. We are trying to affect you, and we're trying to affect your MRIs, right? We want to affect you because we want to decrease relapses, right? Those symptoms that come on, last for a certain period of time and go away. We want to prevent new spots on MRI, okay? And then we want to slow progression of disease. So that's what we're trying to do. MS treatments are very different from other treatments because normally you think if I have a pain, right? So when I go home, my feet are going to be hurting from walking in these cute shoes, right? And so if I take a little ibuprofen or a little Motrin, then my feet might feel better, okay? With MS therapy, we cannot necessarily fix the symptoms that are already there with our disease-modifying therapies. We want to try to prevent new things from being broken. So we can't fix what's already broken, but we want to try to prevent new things from being broken. If we want to try to fix everyday symptoms, that's what symptomatic management is for. All right, so priorities. I'm going to go through this very quickly. When you're talking with your doctor about disease-modifying therapy, these are the things that we try to balance. My graphic got a little messed up when I switched the slide background. But basically, we want to look at effectiveness, we want to look at safety, and we want to look at tolerability, okay? So we want you on a drug that's effective for your MS. You look at the safety profile and concerns and talk about those with your doctor, which ones you feel comfortable with. And then we also want it to be tolerable, right? We have enough options now where most of the time you don't have to take a medicine that makes you feel bad, okay? So we have options where you can find something that's tolerable that will treat your MS, okay? And you can decide on the safety profile of your comfort level. All right, other treatment considerations. Sometimes there are side effects with some of our medicine. Sometimes your doctor will talk about what order to put certain medicines in. And then it's also important that whatever medication you guys decide, if there are blood tests or lab tests that need to be done, that you get those done on a regular basis. So we want to make sure you're safe. All right, so symptoms of MS, we talked about some of these, okay? But this is a really cute graphic I like that just talks about some of the frequency that people reported having certain symptoms. So numbness and tingling in this particular study, 70% of the folks who were surveyed said that at some point they had numbness and tingling. Fatigue, 89.6%. Okay, so almost 90% of folks who took this survey said they had some fatigue. Walking difficulty was very common, 76.4%. Pain was also very common. I'm not going to talk about pain tonight, but pain is a very common symptom that occurred with MS. And if you think 10 years ago, we used to say MS doesn't cause pain, but it absolutely does for a variety of reasons. All right, so let's talk about symptomatic management, and I'm only going to cover about 3 topics. One of them is fatigue, right? So this is my favorite fatigue picture because this is how I feel after I put my kids to bed, actually. So MS fatigue is very different from your run-of-the-mill fatigue, right? So today I got up, I went to work, I was on call, I got in the car, I drove down here, I'm going to drive back home and probably have to do some work when I get home, and I'm going to be tired, right? But MS fatigue is different from that. People generally describe it as different from your run-of-the-mill tiredness after a long day. It can occur on a daily basis, and it usually is worse as the day progresses. So people will say, Dr. Williams, I wake up with this amount of energy. If I use it by 10 o'clock, I'm done. I'm going to try to stretch it out until 2 o'clock, but then I'm done, right? So it's kind of like you hit a brick wall, and when you're done, it's over, okay? It can interfere with daily activities if it's severe. I heard one person describe it as walking underwater with a fur coat on. Heavy, right? That's heavy. Yeah, a wet fur coat. All right, good. Okay, how about causes of fatigue? What causes fatigue? Certainly the MS can cause fatigue, but as Rebecca was saying, as Rebecca was talking about some of the emotional symptoms and changes with MS, there are other things that can cause fatigue. So how about interrupted sleep? Right? So, Dr. Williams, I'm so tired, you got to put me on something for fatigue. Well, how much are you sleeping a night? 3 hours. Okay. Well, you're not going to feel well, and you're going to be tired if you sleep 3 hours a night, right? Depression, okay? Depression can certainly cause fatigue. Rebecca talked about sleeping too much, not sleeping enough. Medications, right? If you take medications for some of the symptoms like numbness and tingling or spasms, sometimes those medications can make you sleepy, right? Or cause fatigue. And then there are other medical conditions like hypothyroidism that sometimes can cause fatigue. So what I tell people is that often there's this much from the MS, okay? And then let's say you got insomnia and you're only sleeping 3 or 4 hours a night, makes the problem this bad, okay? And then let's say you're taking some medicine for spasms, problem gets this big, okay? And then if you're stressed or depressed on top of it, the problem is this big, okay? The problem is that big, but really this much is from the MS. So you have to make sure that you're working with your doctor to try to identify those other causes and make sure that we're addressing those so that we're not blaming it all totally on the MS. Okay, how about treatment? So we try to identify secondary causes, talk with our doctor about that. If you have other medical illnesses, we want to make sure that we're treating those, okay? We want to adjust medications and manage additional symptoms. So we have to look at the whole picture because everything is not just the MS. Say it with me. Everything is not the MS. Okay, say it with your chest. Say it with your chest like you mean it. Everything is not the MS. Right. So the MS does cause a lot of symptoms, but we want to make sure that we're not calling our doctor and saying, oh my God, my MS is out of control, because I'm so fatigued I can't function, but you're only sleeping 2 hours a night. Okay. So we have to make sure that we're addressing the whole picture. Very good. All right. How else can we address fatigue? Lifestyle modification. There's a part you play and there's a part the medication plays. Okay. So what can you do to help with fatigue? Prioritize activity, okay? Superwoman has left the building and lost the key, okay? She is out of here, all right? So take some of those capes off, superwomen and supermen. Sometimes if your body is telling you you need to rest, then rest, okay? Prioritize activity. Conserve or manage your energy. If you know you have a big event, then don't go running around town and run 50 errands and then you sleep at the dinner or what have you. Okay. How about cooling strategies? It's much hotter here than it is in Atlanta, and it's hot in Atlanta. Okay. So cooling equipment will help. Keeping your core body temperature cool will help with fatigue. Assistive devices for mobility, if you need them, canes, walkers, chairs. Exercise will help. Okay. Exercise can actually improve your energy and stress management. Okay. Because we said fatigue can be caused by depression. All right, so what about balance? So how does balance work? There are 3 things that play into balance. So there's vision. You have to be able to see to be on balance, okay? Sensory changes, so you have to be able to feel where your feet are, where you are in space, okay? And then your inner ear. So if any one of those is off, it can cause your balance to be off. So sometimes if people have bad neuropathy symptoms or numbness in their feet and they can't feel where their feet are on the floor, then they're not going to be balanced. Or if you have trouble with your vision and you can't see, then you're not going to be balanced. Okay, if you have infections in your inner ear, that can cause your balance to be off. Also, we have to remember medications. Some medications can make you feel dizzy and off balance. So again, With any symptom with MS, we look at how much we think is related to MS, and we look at how much may be related to other things and try to balance that out. Treatment, usually physical therapy. If people need assistive devices, that can also help. Obviously, if you had some type of inner ear infection, you would want to see your doctor and get treated for that. Okay, how about cognitive dysfunction? Anybody know anything about cognitive dysfunction? Yes? Yes, no, maybe so. When Dr. Hughes was here, we used to call them MS moments. Anybody remember that? Everybody would come in and say, Dr. Williams, I was having an MS moment, right? So that's like when you walk in that room and you forget what you were going to do and you got to walk right back and sit down, or, you stop mid-sentence because you couldn't remember what you were trying to say. We used to call those all MS moments. So cognitive dysfunction, also very common from MS. The most common issues that we see related to cognition or thinking are slowed processing, right? Takes you longer to take in information. You may have to read something 3 or 4 times to kind of take it in and get it for it to sink in. Also, there's difficulty with attention and concentration. So people often report that they have problems with multitasking when they used to be very good at it. And then when you add all those things together, it kind of equals a memory problem, right? So it takes you a little longer to take something in. Maybe your attention is, you get easily distracted. And so then your short-term memory is affected. All right, so how is that evaluated? So there is a type of test called neuropsychological testing that can be done to help us kind of sort out what parts of the memory problems may be related to the MS. They can also tell us about fatigue, if there are issues with fatigue that may be affecting the cognition or thinking. And it can also tell us if there are issues with stress that can affect cognition or thinking. And then also we want to make sure that we're assessing for secondary causes. So we see a pattern here, right? With many of the symptoms of MS, fatigue, balance, cognitive dysfunction. If you're taking certain medications, it can affect those things, right? For cognitive dysfunction, how many people know if you're tired, you can't think straight? Yes, no, maybe so. I mean, maybe you could when you were in college and you were 20, but my second daughter almost took me out of here. I was like, okay, what is my name today? Like, she was wearing us out. Okay, so fatigue, you can't think well when you're tired. Medications can affect your thinking. And then also depression, again, can cause cognitive symptoms that are very similar to what we see to MS. Okay, treatment is rehabilitation if we need it. There is such a thing as cognitive rehabilitation. Also, patient and family education is key. So when you go to the doctor, when we have programs like this, it's important to bring your family and the people that are around you. Why? Because it can be very frustrating, right? If they're saying, Loretta, I told you that 10 times yesterday. Didn't I tell you that 10 times yesterday, right? Okay. And it's really the MS that's causing you not to remember. But if someone's looking on the outside, they may think that you're not. I'm sorry, I called. I know you. I'm sorry. Scratch your name off the tape. Don't put it anyway. But all of that to say, for someone on the outside who doesn't really understand, it can be very frustrating. They may think that you're not paying attention. They may think that you're intentionally ignoring them when it really is a part of the disease. So education of the people around you is key, right? Counseling is also important, and medications, if we need to help with fatigue, can also help cognition in some cases. All right, how about bladder dysfunction? Everybody's favorite dinner topic, right? Everybody wants to talk about their bladder while they're eating, okay? So bladder dysfunction, this is the last symptom I'm going to talk about. 80% of folks with MS experience bladder dysfunction at some point in time. It can happen very early on or late. It often is related to spinal cord disease, and it usually comes in 2 categories. So I say, gotta go, or gotta go and can't go, all right? And sometimes people have a combination of both of those. Okay, so how is that evaluated? So, of course, if someone has an acute change, right, a new change in their bladder function, the first thing we want to make sure is that there's not an infection. So it's important to go to your doctor, be evaluated, have a urine test to make sure there's not an infection there, okay? And then also, there are different types of tests that urologists can do to assess your bladder and see how it's working or what parts of it aren't working. This is a symptom, again, that we do have treatments for. There are some medications that can help you hold on longer so that you don't have accidents or urgency, as we call it. In some cases, if the bladder dysfunction is very severe, some people need catheters to control the urine. There are Botox injections that can be done in the bladder, okay? And also in very severe cases, there are bladder stimulators that some urologists will implant to help control the bladder. However, it's important to recognize that there are some bladder stimulators that will prevent you from having an MRI, okay? So you need to make sure you talk to your neurologist before you have one of those done, because some of them may prevent you from ever having an MRI. All right, I'm coming along the end of the curve, I think. All right, so how about comprehensive care? I'm going to talk a little bit about building your team, and this is just a very succinct, well, kind of long definition about what is comprehensive care with multiple sclerosis by the National Multiple Sclerosis Society. I'm not going to read that to you guys, but I'll read the last sentence. The goal is comprehensive, coordinated care to manage the disease and promote comfort, function, independence, health, and wellness. So just like we say it takes a village to take care of a child, it takes a village to take care of MS, right? So how many people have more than one doctor if you have MS? How many people have more than 2 doctors? How many people have more than 3 doctors? How many people have more than 4 doctors? Right? So depending on what symptoms you have, you may have several specialists that you see and coordinate to take care of those different parts of what's going on with you. So what about the neurologist? So the neurologist is the one who usually orders the MRIs. They help with your disease-modifying therapy, that second layer of the cake. They also help with symptom management. If you need equipment like a cane or walker or wheelchair, they help with that, and they can refer you to other specialists. Primary care physicians help manage your general health concerns. It's important to have a primary care physician or a PCP, because I do not want to treat your cold or your sinus infection. Okay, so it's important to have a PCP, okay, to manage those things. And then also mental health providers, right? So many people see a psychologist or a psychiatrist, okay, and they also can do neuropsychological testing if it's a neuropsychologist. Care partners, extremely important. They're the ones that are home with you on a regular basis, okay, and can kind of see what's going on with you. It's important to involve healthcare partners in your doctor visits, because oftentimes they notice things that you would not notice. For instance, someone will come into the office. I say, "Hey, Miss Smith, how you doing?" And she's like, "Great." And her husband's like, "She is not doing great," right? And sometimes they're just things that you don't see or you don't notice, right? So they may say, the memory has been a little worse. This has been a little worse. I had one lady in the office that was arguing with her husband. He was like, "You fell." And she was like, "No, I didn't." He was like, "You fell." And she was like, "No, I didn't." She was like, "When?" And he was like, "So-and-so and so-and-so date." She was like, "Oh, I did fall." And I was like, okay. So sometimes they tell you things that you don't remember. Okay. All right. And this is just a slide talking about unmet needs and burden of treatment by this group called MS in the 21st Century. It's a group in Europe. And again, I'm not going to read all of these, but they were talking about some of the ways to improve communication between people living with MS and their doctors. So they want to raise the quality of patient interactions, to optimize their time with the doctor, make sure that there's awareness of hidden symptoms and how these can be managed. Okay. They also wanted to encourage multidisciplinary teams to talk to each other. So have the urologist send the notes to the neurologist so everybody knows what's going on. So all of these things were important to help make sure that you guys get the most out of your doctor visits. All right. And finally, be your own best advocate. Okay. So you come to programs like this to increase your knowledge, understand your medications and your side effects, why you're taking what you're taking, and be a part of a community. Right. It's important to have people around you who understand what you're going through. Okay. Other things that you can do for yourself are to exercise and make sure you eat a healthy, well-balanced diet. And I like this quote: "When I is replaced by we, even illness becomes wellness. And all I need is peace, love, and a freaking cure for multiple sclerosis." Thank you guys so much for your time and attention. 35 minutes and 59 seconds. Right on time.
All right. Now, first question's here. And who's got the second question, though? Great. That's where I'm going next.
I know we've got a lot of MS medicines, have there been anything to look at heredity? I mean, at all. I mean, I've been working with it, saying it's there. I've got 4 family members that has MS, and I don't mean third cousin all the way down. I'm talking first cousins, and they're all on one side. On my dad's side, that's where all those cousins was. So, it makes me think, okay, them genes over there wasn't good.
Look, don't be talking about your daddy's genes like that. Right, so
So he can't defend it now, but anyway.
Maybe she wasn't wearing Levi's.
Okay, so great question,
yeah.
right? So many people do ask, what is the genetic component of MS? So there is definitely a genetic component, but it's not a disease that is considered directly inherited. So if you think about something like sickle cell, right? Everybody heard of sickle cell? If mom has a gene, dad has a gene, we can predict 1 in 4 of the kids will have the disease. With MS, there are over 150 different genes in different combinations, and to be honest, we don't know what a lot of the genes actually do. So if you have a family member with MS, usually a first-degree relative, your risk is increased, okay, by about 4%, but the risk overall is still very low. If you look at studies that were done of twins who have the same DNA, right, the same genes, if one of them develops MS, the other one has about a 25% chance of developing MS, okay? So the whole story is not in the genes. The genes do tell a part of the story, but there's some other environmental factors that seem to be interacting to lead to one person having MS versus another. I do have many families where multiple people have MS, but I have just as many where that person is really the only person and they don't know other people in their family. So there's just a lot that we have to learn. Do you think you want to add to that?
And to the part of it is, are there studies going on or things like that? There are increasingly MS registries where everyone can sign up, and we're sort of kind of not on a particular drug doing a study, but on everyone to try and get more information. So I don't know of any direct genetic studies with an individual family or something like that, but we are looking at getting that information so that we can get a better picture. Because all of us have had, brothers and sisters, mothers and daughters, cousins and things within clinics. So we know that's a component of it.
Next question.
You mentioned bladder stimulators. Is that for patients that have trouble getting started? Can you elaborate on the bladder stimulator a little bit?
Right, so I'm not a urologist. Let me put in my disclaimer. No. Although, on call in the middle of the night, people did often get neurology and urology confused. So they would call me in the middle of the night and be like, yeah, somebody can't pee. I'm like, wrong person. Hang up right now and walk away.
She's on call. She's been traumatized.
Exactly. So the bottom line is, the bladder stimulators can help with people. I think it's generally for people who have frequency, where they go a lot. The honest answer is you would have to be evaluated by a urologist, and then based on the testing that they do, they could tell you if you'd be a good candidate or not. But the reason that I also mention it is, again, because some of them are not MRI compatible. So before we do an implant, okay, make sure you talk with your neurologist, because that may mean you can never get MRIs again to evaluate your MS. So have to find that balance.
A lot of the stimulators, too, people sometimes don't understand why they're having bladder trouble. So you may be like, well, I got to pee all the time. And it may be because you're not emptying all the way. So your bladder's over full and it never empties out all the way. And then you drink a little bit more and you got to go again. So you're going every 10 minutes, but you're never emptying it out altogether. So a lot of the stimulators kind of work to make the bladder empty out, and so it gives you better control when you have frequency or urgency, but mainly because you're more properly emptying. Some of them can help with bowels too, but like Mitzi was talking about, we recommend waiting until your disease is kind of stabilized, because if you're early on in diagnosis, we may help one symptom, but then have a harder time understanding the disease overall and what's going on. So,
Next question's here.
Being in a relationship with someone with MS, you said that the partner would have some symptoms. the partner will have some symptoms. Can you name off some of the symptoms that the partner will have?
Trouble dealing with you? I'm just kidding.
Really? Really?
I'm just kidding. I know her. I would never say that out loud. No, so usually like a care partner or person that we're kind of in our life, be it a spouse, a boyfriend, girlfriend, or even like a child or parent or neighbor, they're going to deal with things emotionally as far as having to come to a level of acceptance with someone they care about being sick. But they're not going to experience neurologic symptoms from MS.
So it's not like pregnancy, like where my husband got a gut that looked like mine while I was pregnant. So it's not quite like that. But great question. Thank you for asking. Yes.
There is conversation now about gadolinium and the effects it may have on people. Can you talk about whether or not you recommend gadolinium and why? And if somebody has had a very stable MRI for years, would you recommend them having gadolinium again, given that it's somewhat toxic?
So that's a great question. The honest answer is the jury is out for to a certain extent, right? So what she's asking about is the gadolinium, the contrast that's injected when we do MRIs. There have been studies that suggest that it hangs around in the brain for long periods of time. There have been a couple of studies, or at least one that was released, that suggested that we didn't see any overall harm at this point, but we honestly don't know because it's just starting to be looked at. So in general, especially early on in MS, if we go back to that graph, remember in the beginning, all of those arrows on the bottom where we saw active lesions. So very early on in disease is where we see those active lesions very commonly. So usually I do recommend gadolinium for those MRIs because it tells us about new disease activity, even in old spots. So people can have enhancement in old areas and they can have an enhancement in new areas. For people who are very stable for a long time with their MS, again, it's something you have to kind of sit down and talk with your doctor about. If it's been very stable for a long time, sometimes the MRIs are not that frequent. Sometimes they're every 2 years, or in some cases every 3 years, depending on what treatment a person is taking. So if the exposure is every 3 years or so, I probably would still recommend it. But again, an individual decision you sit down and talk with your doctor about.
I think, too, for me personally, sometimes it depends on the burden of disease. So if it's someone who has one lesion and then we see another lesion, we can kind of know the time frame with when it formed. But because sometimes old lesions can become active again, especially and cause symptoms, sometimes people have a heavy burden of disease, which means when I look at the MRI, there's lots of white spots. And so the only way that I can know that the MS is changing is because one of them is active. And I may not have known that just comparing it from the old one. The contrast helps. So usually, like Dr. Williams was saying, that's a case by case, ask your doctor, and maybe even MRI by MRI. They may say it's important one time based on your symptoms, and another time say, no, it's okay, we can pass. So,
So for instance, for some people who take some of our infusion medications, we may get more frequent MRIs, right? So if we get 2 MRIs a year, both of those won't necessarily be with contrast, right? Or if we get MRIs every 3 months, there'll only be one with contrast and the others will be without. Hopefully that answers the question.
Okay. Next question.
Hold it. Okay. Do you always have to go through a washout period to change medicines? To change your MS medicine?
So the answer is no. So washout periods are something that are really kind of invented by physicians and providers or practitioners. With most of our medications, when they're approved, they don't give us a specific washout period where they say a person has to be off of this medication before they start this new drug. It just depends on how the medication works and the comfort level of your physician, how long they feel that you should be off of one medication before starting another one. But the drug companies and the FDA does not specify that people have to wash out of one drug or a specific period of washout before they start another one.
and I think sometimes it depends on why you're switching and the 2 drugs you're switching to. So that's often, again, a case by case. What medicine were you on? What medicine are you starting? and it may not be the same. You may need a break off of one per your doctor, and if it was a different medicine, they may say, oh no, you can take it the morning of till you start the next drug. So there have been some studies where we looked at medicines taken together, but in general now we do recommend at least stopping one before starting another, but as to how long you need to stop it or be off, it depends.
And also, if you have blood tests that are abnormal, sometimes we need a washout to make sure that your blood tests come back to normal before we start you on something else that could affect that part of the body.
About the bladder situation that we were talking about having something basically instilled in you to help you with your bladder, and you were saying that you might not get any more MRIs. Is that a really good thing to do?
Worth it or not?
So, right. So again, those are just possible ways that bladder issues will be treated. Most people do not have bladder stimulators put in. Most of the time, we are able to help the bladder symptoms related to MS with the other things that we talked about with medications, in some cases with Botox injections or catheterization, those types of things. So that is not like a first line, like you go to the urologist, they're going to say, get surgery, okay? But, I put it on there because for some severe cases, people do need the bladder stimulator, and we just have to be aware of the MRIs. But that is not like the first line of treatment when you go to get treated for that.
Before I get to the next question, how many care partners are in the room? Can you raise your hands? Everybody thank them for being here. All right? Very important people, all right?
Absolutely.
Very, very important, and you all should be acknowledged for being a care partner. There's a lot that has to say about that. And speaking about that, if any of you have a question, it's not just for the patients, all right?
Absolutely.
So if you have a question to ask, please raise your hand and let me come over to you too, because you might definitely have you should probably have questions for either one up there, okay? I'll hold it.
Yes. So my question was about keeping track with medication. So I haven't had any relapses in a long time, so my neurologist had suggested that I can stay off of my regular medication and just focus on symptom control. But my symptoms weren't really being handled with the medication that I'm on. Like I mostly have pain, and so I have what's it called, nerve pain medication, but it hardly helps. It usually makes me sleepy, and that's it. So I'm just curious as to like what kind of management am I supposed to be looking for?
It's hard case by case, especially not knowing like full history or kind of entire medical record for us to give personal advice. So certainly everybody responds to medicines differently, even the same symptomatic medicine. So it would be really easy for us if everybody who had bladder urgency, we could put on the same pill. But as we were talking about with other things, sometimes we have to use a whole wheelhouse of things because what works for one person may not work for another. So as to the pain, oftentimes we would say, okay, well, we failed this, let's try something different. Or maybe even getting a specialist involved, sort of like with the bladder and getting a urologist, you could see a pain doctor. As to the other side of your MS being well controlled and stopping a medicine, that's still sort of a hot topic and is debated within the MS community. So some people will still say if you hit a certain age, because of immunosenescence or kind of the calming down of the immune system, maybe you don't need an MS medicine. Or because it's been a certain number of years, maybe you don't need it and you could stop it. But other people would be very far in the other camp and would say you should never stop it, you should always be on something. So I'd be hesitant to give too much advice one way or another, but certainly I've personally been surprised. So I've had some people who I've said, yeah, it's okay, it's been a very long time, it's been 20 years, you haven't had a relapse, it's probably safe, and then they have a relapse. So even for me, similar to Dr. Williams, I'm sure, after a decade of kind of dealing and treating MS, I think about things differently as far as stopping medicines or what's safe or what isn't.
Next question.
My question is, I don't know if I am depressed or not. I absolutely cannot clean my house. I can get started say like in the bathroom, and it may take me 2 or 3 hours just to do the bathroom. I think that's why I can't make myself go any farther than that. I have help. I have a friend that I pay, to do my house whenever I can. But does that sound like a symptom of depression to you, or is it just that I physically can't do it?
So again, it's difficult to give personal medical advice, without seeing you and kind of knowing your history. What I will say, though, and I actually had a couple slides about depression, but I took them out because Rebecca was covering that. She covered it very thoroughly. But there are often symptoms of depression that are not your typical sadness, right? So many times when people think of depression, they get a picture of somebody that's not combing their hair, they don't brush their teeth, and they come to the door in a bathrobe and they just can't function. But there are a lot of people with functional depression, okay? So symptoms of depression that are not kind of your run-of-the-mill sadness and crying are if people are isolating themselves, if you don't have, what's the word I want to use? You lose interest in things that used to interest you. I don't know how interested you were in cleaning your bathroom before, but, things that you used to do very well, you have no interest in them, okay? It's a word called anhedonia, right? So a lot of people will say, well, I used to, when I get stressed out, I would clean up, or I'd do this, or I'd do that, but I don't do that anymore, okay? So it's always important to talk to your doctor and see what other symptoms you're having and see how that needs to be addressed. But the bottom line is that there are many other symptoms of depression aside from just sadness and crying. So if that is even entering your mind, it's something that you should address with your doctor to make sure it's being addressed appropriately.
And I think it's part of like what she was talking about with anhedonia or not wanting to. It sort of goes to the why. Are you not being able to get your house cleaned because you're not motivated and you feel sort of down and you can't make yourself do anything and you're not getting out of the house? Or is it that it's physically difficult and you really want to and are motivated to, but you lose energy or you're weak and so it's more taxing to do it? Or is it that you hate cleaning your house? And so, I don't usually clean my whole house either, and that's nothing to do with a physical ability. I just can kind of only do part of it, and then I don't want to do anymore. So depending on the why is more important maybe than the task itself, because if you hate doing something and aren't doing it, that may not be depression, that just may not be doing it. But it could also be a sign that maybe we need to help another symptom or get MS a little better under control.
I was just going to say, you're not by yourself. There's a lot of us. If they raise their hands, cleaning your house is just too much. It's way too much work. Our fatigue level is like, So you cleaning your bathroom, if it's 2 hours, 3 hours, that's great you did it, because we'll do one room and the next room you're like, whatever. So don't think it's just you.
And maybe not a priority anymore. There may be other things for our energy more important.
You talked about brain atrophy and it being more prevalent in people with MS. How does that affect lifespan?
Right, so that's a great question. So MS is thought to slightly decrease the lifespan. So if you look at studies from our very, very early drugs, like our beta-furon drugs, they have done some studies looking at lifespan, and it looks like for MS it may be decreased by average of 8 years. So not, hugely decreased, but it may be slightly decreased. And it's not necessarily because of the brain atrophy, so to speak, right? So I usually tell folks MS itself usually does not kill people, right? If people die of complications of MS, it's usually for the same reasons that other people who are very debilitated die, right? They can't move and they get an infection. So it's not a function necessarily of the brain atrophy. It's more a function of the overall level of disability that can accumulate over time. Now, brain atrophy can be related to things like cognitive problems. So that's the primary correlation between brain atrophy and MS symptoms, is that the more atrophy people have, the more cognitive issues they may have. But the atrophy doesn't necessarily directly link to the decreased lifespan, to my knowledge. Yeah.
Time, 3 more minutes of questions.
All right.
First of all, I really appreciate this because this is the first time I'm getting a chance to get this, and this is really helpful for me. So as far as being a caretaker, we also have teenage boys, right? So just teenage boys in themselves add to the problem of trying to clean a home.
Yes.
So is there something, some place, some literature, something that you guys can help? Because it's hard for me to fathom this. She's one of the ones that I always say, you look so good, but she's always constantly in pain. Is there something that you can recommend that our boys can kind of look at and try to understand what she's actually going through to actually try to be a little bit more of a help?
So we're having a family day in
See
Augusta.
that? Bam, right there. I was just
Not
gonna
to
suggest
toot our
family
own
day.
horn, but on the 15th actually of September, we do a program that's designed for people who maybe can't come to the clinic. And as part of that, there's a teenage breakout session. So specifically focused on either teens who have MS, because we do have a handful of teenagers in Augusta who are living with MS, and their ability to talk to then teens whose parents or grandparents or aunts or uncles have MS. So that's one. Sometimes there's local resources, and then there are support groups designed for teens and also for children. And so there are things out there, but still as parents, you sort of have to monitor that because there are so many, I hate to say untrustworthy, but maybe not as reliable sources on internet and some of those Facebook groups and things like that. So Stuart does a really good job of that with MS News and Views, and you can look to some of the other bigger MS organizations as a starting point because they're also, more so than me, I mean, teens are so tech savvy. They love being able to go to a website and kind of do it. And a lot of them even have apps now on their phone that they can download to get more information.
Yeah, so if you look at places like the National MS Society, the MS Foundation, I believe that a couple of them may have brochures for children of people with MS. The other thing is I tell people, bring them to the doctor's appointments, right? I have people that bring their teenagers. We look at those MRIs, right? They have a chance to ask questions in a small room. Nobody feels threatened, and we look at the MRIs. We say, this is what's going on. And do you have any questions about what's going on with mom? What do you observe with mom or dad or what have you? And it can be very helpful. So, I encourage bringing them into part of the conversation as you feel that they can, handle, the issues related to the MS. But yeah, bring them to the visit. Yeah. Okay, I think, is that it?
Yeah.
Okay.
Thank you very much.
Thank you, guys.
Thank you.
Have a great evening.
Thank you.
All right.
And thank you for Mitz. We love having Dr. Williams back.
Absolutely.